Welcome back to the deep dive. If you're like us, you sometimes find yourself, staring at a pile of revision notes, trying to pull out the absolute essentials. That's exactly what we're doing today. We've got detailed notes here on diabetes insipidus.
Right. DI?
And our mission, basically, is to filter out the high-yield stuff, the bits you really need to know, make it stick.
Yeah, think of it as a guided tour through the key facts.
Yeah.
We'll break it down, make it manageable, whether you're prepping for exams or just need a quick, solid understanding.
Okay, let's dive in then. First things first. What exactly is diabetes insipidus? And crucially, this isn't the diabetes most people think about, is it? The sugar one.
No, absolutely not. That's a really important distinction. Forget blood sugar. Diabetes insipidus, or DI, is completely different. It's all about water balance.
Water balance.
Yeah, the defining features are, well, two main things. Excessive thirst, that's polydipsia, and passing huge amounts of urine, which is polyuria.
Okay, so if it's not high sugar making you pee constantly, what's going wrong?
The root cause is a problem with how the body regulates water. And it all comes down to a hormone called antidiuretic hormone, ADH.
ADH, aka vasopressin.
That's the one, vasopressin. It's made up in the brain, in the hypothalamus, then stored and released by the pituitary gland just underneath.
And its job is?
Its job is basically to tell your kidneys, hold on to water.
Okay.
When ADH reaches the kidneys, it signals them to reabsorb water back into the bloodstream rather than letting it all go out as urine. Your body naturally releases more ADH when you're getting dehydrated or, your blood gets too concentrated.
So if that ADH signal gets messed up somehow, the kidneys just don't get the message to save water.
Exactly. They can't reabsorb properly, and you end up producing, just massive quantities of really dilute urine.
And that leads to the thirst because you're losing so much fluid.
Precisely. It's a cycle. The notes break down why the ADH system might fail into two main categories.
Okay, what are the main types?
First up is cranial DI. Here, the problem originates in the brain, the cranium. Either the hypothalamus isn't making enough ADH, or the pituitary isn't releasing it properly.
So, a supply issue from the brain.
Correct. Think of it as a hormone supply problem.
Got it. Supply problem. And the second type?
That's nephrogenic DI. Nephro meaning kidney related. In this case, the brain is usually making and releasing ADH okay.
The supply's fine.
Right, the supply's there. But the kidneys themselves aren't responding to the ADH signal. It's like the message arrives, but the recipient can't read it.
So a response problem at the kidney level.
Exactly, a hormone response issue. But the end result for both types is pretty much the same, that excessive thirst and very dilute urine.
Okay, supply versus response, cranial versus nephrogenic. That makes sense. The notes also mention a couple of others briefly.
Yeah, just quickly, there's gestational DI. This can pop up during pregnancy because the placenta sometimes produces an enzyme that breaks down the mother's ADH too fast.
Interesting.
And then there's primary polydipsia. This one's different again. The ADH system might be fine, but there's an issue with the actual thirst mechanism itself, making someone drink excessive amounts of water, which then naturally leads to lots of urination, sometimes called dipsogenic DI.
But cranial and nephrogenic are the big two.
They're the main players, yes.
So what causes these main types? What can damage the brain's ADH production or make the kidneys resistant? This sounds like prime revision territory.
Absolutely high yield. For cranial DI, the brain supply issue the notes lists several causes. Acquired causes are most common. Think brain surgery near the pituitary gland.
Right.
Severe head injuries or tumors in that region, like craniopharyngiomas, things that physically damage the hypothalamus or pituitary.
Makes sense. Direct damage.
Yeah, less often it could be things like infections, meningitis maybe, or inflammatory conditions like sarcoidosis affecting the brain, or even vascular problems like a hemorrhage.
Okay, so quite a range of potential brain insults. What about nephrogenic DI, the kidney resistance type?
Again, acquired causes are important here. And the big one, the really high-yield one to remember, is medication, specifically lithium.
Lithium.
Yeah.
Used for bipolar disorder, right?
Exactly. It's notorious for causing nephrogenic DI. It interferes with how the kidney tubules respond to that ADH signal.
That's a Q link.
Definitely. Other acquired causes include significant electrolyte imbalances, think very low potassium or very high calcium levels in the blood. These mess with kidney function.
Like hypokalaemia or hypercalcaemia.
Precisely. Also, chronic kidney disease itself, or problems after a urinary tract blockage.
So lithium, electrolytes, kidney disease, those are big triggers for the kidneys becoming resistant.
They are. And just like cranial DI, there can also be genetic forms of nephrogenic DI where people inherit faulty kidney receptors or water channels, but these inherited types are much rarer.
Okay. And you mentioned a mnemonic earlier for a specific inherited syndrome.
Ah, yes, DIDE mode. That's for a rare genetic condition, Wolfram syndrome. The mnemonic helps remember its features. Diabetes insipidus, diabetes mellitus, the sugar type unusually paired here, optic atrophy, and deafness. Dead mode.
Dead mode. Got it. Useful for that specific rare case. So we've got head trauma, brain surgery, tumors, lithium, electrolyte issues. Quite a list.
Yeah.
Based on that, who's most at risk?
Well, the risk factors follow directly from those causes, don't they?
Yeah, seems logical.
Someone with a history of recent brain surgery near the pituitary or a significant head injury, they're at risk for cranial DI. If someone has certain types of brain tumors, that's another risk.
Makes sense.
For nephrogenic DI, the big one is long-term lithium use. Huge risk factor there. Also, people with chronic low potassium or high calcium or those with advanced kidney disease.
Okay, so if you encounter a patient complaining of excessive thirst and urination, you need to ask about these things. Head injury history, medications like lithium, any known kidney or electrolyte problems.
Exactly. That history really helps narrow things down and puts DI higher up your list of possibilities. It's all about those clinical triggers.
Right. Let's dig into the how a bit more, the pathophysiology.
Mm-hmm.
Can you walk us through what's actually happening at a sort of mechanical level in each type?
Sure. Let's take cranial DI first, the supply problem. Your brain isn't making or releasing enough ADH.
Okay.
So less ADH reaches the kidneys. Without enough ADH signal, the collecting ducts, the final part of the kidney tubules, they don't become permeable to water like they should.
They stay waterproof.
Kind of, yeah. They don't insert the special water channels, aquaporins, so water can't be reabsorbed back into the body. It just flows straight through into the urine.
Leading to huge volumes.
Massive volumes of very dilute urine. And because you're losing all that water, your blood gets more concentrated, your body gets dehydrated, and that triggers intense thirst, the polydipsia, as your body screams for water.
Got it. Signal's missing, water leaves, body gets thirsty. Now, nephrogenic.
Nephrogenic DI, the response problem. Here, the ADH is being produced and released by the brain. The signal is sent. But when it gets to the kidneys, the kidney cells either don't recognize the ADH because the receptors are faulty, or the internal machinery that should respond to the signal is broken, often linked to those causes like lithium or electrolyte issues.
So the message arrives, but it's ignored.
Pretty much. Even though ADH is present, the water channels don't get inserted properly into the tubule walls. So again, water can't be reabsorbed effectively.
The result is the same.
Same result.
Yeah.
Lots of dilute urine, dehydration tendency, and that compensatory intense thirst.
Okay, so cranial, brain not sending the signal, nephrogenic. Kidneys not listening to the signal. Simple way to think about it. What should clinicians or even the patient themselves be looking out for? What are the key symptoms?
The absolute core high-yield symptoms are those two Ps we keep mentioning, polydipsia, excessive thirst, and polyuria, excessive urination.
And you really mean excessive, right?
Oh, absolutely. The notes stress this. We're not talking about needing to pee a bit more often. Urine output can be huge. Often 3 to 4 liters a day is the lower end for suspicion, but it can easily go up to 10, 15, even 20 liters or more in severe cases.
Oh, 20 liters. That's a staggering. You'd basically live in the bathroom.
It massively impacts life, yes. And all that peeing means getting up multiple times a night, nocturia. That's very common.
Exhausting.
Definitely. Because you're losing so much water, signs of dehydration can appear: dry mouth, dry skin. People might feel fatigue, irritable. In babies, irritability might be the main sign. And in severe, prolonged cases, you can get weight loss and significant electrolyte problems.
Okay. And on examination, anything specific besides dehydration signs?
Well, the onset can be quite insidious, gradual. People might adapt for a while by just drinking constantly. The key objective finding really is measuring that urine output. If a 24-hour collection shows consistently over, say, 3 liters, that confirms significant polyuria and needs investigation. Sometimes a doctor might feel an enlarged bladder.
Right. So polydipsia and polyuria, 3L day, are the big red flags. But hang on, you mentioned other things can cause this, like Regular diabetes mellitus, how do we know it's DI and not something else?
That's the critical next step, the differential diagnosis. You absolutely have to rule out other causes of polyuria and polydipsia before zoning in on DI.
What are the main mimics?
Top of the list, as you said, is diabetes mellitus, the sugar kind. High blood sugar spills into the urine, pulling water with it through osmosis. Different mechanism entirely.
Osmotic diuresis, right?
Exactly. Then there's primary polydipsia, including psychogenic polydipsia, where the person drinks excessively for psychological reasons or due to a faulty thirst mechanism. Their kidneys are actually working fine, they're just overloaded.
So they pee a lot because they drink a lot, not because the kidneys can't concentrate urine.
Correct. Other possibilities include high blood calcium, hypercalcaemia, or low potassium, hypokalaemia, which can impair the kidney's concentrating ability, mimicking nephrogenic DI, certain kidney diseases themselves, even someone secretly taking diuretic water pills.
Okay, quite a few lookalikes. So how do we figure out which one it is? How do we investigate?
This is where the diagnostic pathway laid out in the notes is key. You start with baseline tests.
Like?
A 24-hour urine collection to confirm the polyuria, 3L. Blood tests to check serum sodium and plasma osmolality. These might be high or high normal if the person is dehydrated from water loss. And crucially, check the urine osmolality. In DI, it should be inappropriately low, meaning very dilute, despite likely dehydration.
High concentration in the blood, low concentration in the urine. Body wants water, kidneys are letting it go.
That's the pattern. But to definitively diagnose DI and, importantly, distinguish cranial from nephrogenic, you need the water deprivation test.
Okay, sounds unpleasant. What does that involve?
It has to be done under close medical supervision. You basically restrict the patient's fluid intake for a number of hours. You monitor their weight, blood pressure, urine output, and regularly measure their plasma and urine osmolality.
What are you looking for?
Normally, when you deprive someone of water, their body releases ADH, and their kidneys respond by concentrating the urine dramatically to conserve water. Urine osmolality goes way up.
Makes sense.
But in someone with DI, because their ADH system is faulty somewhere, their urine remains dilute, low osmolality, even as their plasma osmolality rises and they get dehydrated. This failure to concentrate urine when deprived of water points towards DI. It helps rule out primary polydipsia, where the urine would concentrate normally during deprivation.
Okay, so if the urine stays dilute despite water restriction, it's looking like DI. How do you tell if it's cranial or nephrogenic then?
That's the next step, usually done immediately after the deprivation phase. You give the patient desmopressin, DDAVP, which is synthetic ADH.
The replacement hormone.
Yes, and you see how their urine concentration responds. If, after getting desmopressin, their urine osmolality shoots up significantly, meaning the urine becomes much more concentrated, it tells you their kidneys can respond to ADH. They just weren't getting enough of the natural stuff.
So the problem was the supply from the brain.
Exactly. That indicates cranial DI.
Okay, and if the urine doesn't concentrate much even with the desmopressin?
If the urine osmolality barely changes, stays low and dilute, it means the kidneys aren't responding even to the synthetic ADH. The problem lies in the kidney's ability to react.
They're resistant.
Right. And that confirms nephrogenic DI.
The notes have a table showing osmolality cutoffs for this. Is there a simple way to remember the desmopressin response part?
Yeah, a useful tip is, if the urine concentrates significantly after desmopressin, think cranial DI. If it remains non-concentrated or only minimally changes, think nephrogenic DI. C for concentrates cranial, N for non-concentrated nephrogenic.
C for concentrates cranial, N for non-concentrated nephrogenic. That's brilliant. Really helpful. And sometimes imaging is needed too.
Yes, particularly if cranial DI is diagnosed or suspected, an MRI scan of the brain focusing on the pituitary and hypothalamus is often done to look for underlying causes like tumors, inflammation, or damage from injury.
Okay, so getting the type right using these tests is vital. Why? Because the treatment's different.
Absolutely critical. The management strategy depends entirely on whether it's a supply problem or a response problem, another high-yield area.
So how do you treat cranial DI?
Since the issue is a lack of ADH, the logical treatment is hormone replacement. You give desmopressin, DDAVP. It replaces the missing natural ADH and tells the kidneys to conserve water. It comes in various forms: nasal spray, tablets, melt-in-the-mouth wafers.
Straightforward enough. Replace the missing hormone. Are there catches?
The main one is getting the dose right. If you give too much desmopressin, the kidneys hold on to too much water. This can dilute the body's sodium levels, leading to a dangerous condition called hyponatremia.
Low sodium, right.
So patients need careful monitoring, especially of their sodium levels, particularly when starting treatment or if their fluid intake changes. They might need to adjust doses or sometimes even be advised to skip a dose periodically to allow their body to excrete some free water and prevent sodium from dropping too low.
Okay, treat with desmopressin, but watch for hyponatremia. Now, what about nephrogenic DI, where desmopressin doesn't really work?
Yeah, giving standard doses of desmopressin isn't usually effective because the kidneys aren't listening anyway. So the approach is different. First, ensure the patient has easy access to water and encourage adequate fluid intake to prevent dehydration. That's fundamental.
Stay hydrated.
Absolutely. Second, try to identify and treat the underlying cause if possible. If it's caused by lithium, can the dose be reduced or the drug changed? If it's due to low potassium or high calcium, correcting those electrolyte imbalances is key.
Fix the root cause if you can. Makes sense. What if you can't fix the cause?
Then management focuses on reducing urine output through other means, and this is where it gets interesting. We sometimes use thiazide diuretics like hydrochlorothiazide.
Wait, diuretics, don't they make you pee more? That sounds totally wrong.
I know, it seems paradoxical. But in the context of nephrogenic DI, thiazides can actually reduce urine volume. The mechanism is a bit complex, but basically, they cause a mild depletion of sodium in water, which leads to increased reabsorption of salt and water higher up in the kidney tubules, meaning less fluid reaches the ADH-resistant collecting ducts.
Wow, okay, so thiazides can paradoxically help in nephrogenic DI.
Yes. It's a classic treatment strategy. Sometimes they're combined with NSAIDs, non-steroidal anti-inflammatory drugs like indomethacin, which can also help reduce urine volume by inhibiting prostaglandins in the kidney. High-dose desmopressin might occasionally be tried in milder cases, as there might be some residual receptor function, but thiazides are more standard.
Fascinating. Thiazides and maybe NSAIDs for nephrogenic DI, definitely one to file away. How common is DI overall? You mentioned it's rare.
Generally, yes. The notes estimate prevalence around 1 in 25,000 to 1 in 30,000 people in the UK. So not something you see every day in general practice. Cranial and nephrogenic forms have roughly similar prevalence overall. Inherited forms account for less than 10% of all cases.
But the lithium connection.
Yes. That's the big exception to the rarity rule. Lithium-induced nephrogenic DI is much more common. The notes suggest it can affect up to 40% of individuals on long-term lithium therapy to some degree.
40%. That's huge.
Oh.
Definitely worth knowing about lithium. What's the long-term outlook, the prognosis for people with DI?
With appropriate diagnosis, treatment, and patient education, the prognosis is generally good. People can usually manage the condition and live relatively normal lives.
It requires ongoing management.
Oh, yes. Often lifelong treatment, like daily desmopressin for cranial DI, or careful fluid management and possibly medications for nephrogenic DI. Regular monitoring, especially for electrolytes, is important.
And if it's not treated or managed properly?
Then it can be serious. The main immediate risk is severe dehydration. Chronic dehydration and the underlying condition can lead to significant electrolyte imbalances, particularly problems with sodium, either high sodium from water loss or low sodium hyponatremia from incorrect desmopressin dosing.
What else can go wrong? Any long-term complications?
Well, persistent severe polyuria can potentially lead to complications like urinary tract infections or bladder problems like an enlarged, poorly functioning bladder from constantly holding large volumes. In very severe untreated cases, there could theoretically be kidney damage or neurological problems due to extreme dehydration or electrolyte shifts.
And the notes mention a caution with desmopressin itself.
Yes, a specific point. In patients with known heart problems, particularly ischemic heart disease, desmopressin, DDAVP, needs to be used cautiously as it can potentially worsen myocardial ischemia in susceptible individuals. Might need cover with nitrates. Also, genetic forms of nephrogenic DI, if untreated from childhood, the constant high urine flow can eventually lead to back pressure changes in the urinary tract hydrourea or hydronephrosis.
So managing it properly is really key to preventing these quite serious issues.
Absolutely. Patient education is paramount, understanding the need for medication, fluid intake, monitoring, and knowing when to seek medical help if things change. Regular reviews are important too, especially for those with nephrogenic DI or on lithium.
Wow. Okay, we've covered a lot there, really dug into those revision notes on DI. From the basics, thirst and urination, to the underlying ADH problems in the brain or kidney, the crucial diagnostic tests like water deprivation, and the very different management strategies for cranial versus nephrogenic DI.
It really emphasizes how important understanding that basic physiology ADH action is to figuring out the diagnosis and treatment.
Definitely. We hit the key symptoms: polydipsia, polyuria, the main types. Cranial supply issue, nephrogenic response issue, the key test, water deprivation and desmopressin response. Remember, C for concentrates cranial, N for non-concentrated nephrogenic.
And the treatments, desmopressin for cranial, watch sodium, and for nephrogenic, address the cause, ensure hydration, and consider thiazides.
Thinking about the sheer range of causes we discussed, head trauma, brain tumors, common drugs like lithium, rare genetic faults, electrolyte disturbances.
Yeah.
It's fascinating how problems in such different parts of the body, the brain, the kidneys, even the placenta and gestational DI, can all converge on this single issue of water balance.
It really is.
It sort of raises a bigger question, doesn't it? You wonder, are there other seemingly simple symptoms out there, like excessive thirst, that also hide such incredibly diverse and complex potential causes? It's a good reminder to always think broadly.
That's a great point. Never assume the obvious cause without considering the alternatives and understanding the underlying mechanisms.
Absolutely. Well, if you are tackling medical revision, getting to grips with conditions like DI, pulling out those high-yield facts we've discussed is so important. And for resources that can really help you solidify this knowledge for exams.
You should definitely check out passthemsbo.com.
And for free resources, there's also freemsa.com. Great sites for exam prep.
Really useful materials on both.
Thanks so much for joining us on this deep dive into diabetes insipidus. Keep learning, keep questioning, and we'll catch you on the next one.